Thank you. I'm happy to be here tonight. Thanks for joining this Wednesday webinar. I'm going to be discussing concussion, and I want to try to make it as accessible and straightforward as possible. A lot of the times, unlike other injuries that athletes might experience, concussions really happen as accidents. So it's hard sometimes to completely prevent what could occur, but I want to talk a little bit about helmet safety, and then we'll go into maybe if your athlete experiences a concussion, what to look for and what to expect in the days coming. So first and foremost, unfortunately, there is no helmet that is completely concussion proof. When we measure athletes for their preseason helmet, you want to measure their circumference of the head above the eyebrows and then around the ears, and the helmet should fit very snug. If there's a chin strap, it should also fit snug, meaning when the athlete opens their mouth, the helmet should move down. There is one certifying body which is well reputed, the National Operating Committee on Standards for Athletic Equipment. It's abbreviated NOCSE, and often if you're looking at equipment, you can look inside to see if it's been certified by NOCSE. If the helmet is worn properly, it can undergo a handful of minor hits, but once it's involved in a serious crash, whether that be because of a contact sport, a biking sport, a skiing injury, the helmet must be replaced. It can't be repurposed. And when you're looking at helmets, because a lot of kids, their first helmet comes when they're riding a bike or the scooter, we do want to avoid those really cute ears and spikes on the helmet. These prevent the helmet from smooth gliding, which is a necessary feature of a rounded helmet to absorb some of the impact when it hits a hard surface. So try to just stick to a routine helmet. If they really want something to make it their own, you can try stickers on the side, but we want to avoid those things that go up and down the front that are coming out of the helmet. When somebody has a head injury, what we're worried about in athletics is, are they experiencing a concussion? A concussion often occurs when there's like a blow or a jolt to the head, or even a hit to the body that causes your head and your brain to move rapidly back and forth. This sudden movement causes your brain to bounce or even twist inside the skull, and the downstream result is often chemical changes in the brain and sometimes even stretching of brain cells. The vast majority of sports concussions are considered mild traumatic brain injuries. And if approximately 4,000 concussions are reported a year, the vast majority, more than 90% of these, are going to fully resolve within about 2 weeks, meaning there's not going to be long-term sequelae such as limitations on academic achievement, limitations on social relationships, or limitations in like communication or achievement in a job. So that's some of the good news. If an athlete has a concussion, so one of the most important things that we need to do is we need to remove them from play. They're not going to return to sport on the day of that injury, and they're not going to return to sport until they're evaluated by a medical professional with experience in concussion. That person has to let them know that it is safe to start playing sports again, and this includes practices. The reason why we don't let them play that day is because returning too soon may actually put an athlete at risk for having a second concussion or having prolongation of their concussion symptoms. One of the things that we really worry about in athletes, which has been demonstrated in collegiate athletes, unfortunately, with some fatal results, was an occurrence of second impact syndrome. So the second concussion came rapidly after the first concussion. Those neuronal cells are not stable, and there is additional swelling on the brain. And if you think about it, instead of 1 + 1 equals the effects of 2 concussions, it's almost to the brain like 1 + 1 = 7. And that puts the athlete at a lot greater risk of long-term damage. Once the athlete comes out of play, the things that they're going to report that we're going to ask about, that are common symptoms, meaning self-reported, are things like headache or pressure in the head. They're going to report nausea. They're going to report that they might feel dizzy or have double or blurry vision. They might tell us that they feel bothered by lights or noises that don't bother others. They also might complain of feeling very hazy, foggy, tired. They might say they feel confused, like quote unquote, something's not right, or they might say that they feel like they can't concentrate normally. Those are all symptoms that an athlete can report to you. The signs that you might look for as a parent, a caregiver, a coach, or even as a medical professional would be that they have difficulty recalling events before or after that hit. They appear stunned or dazed. They're forgetting simple instructions. They get confused by assignments, their position on the field. They forgot what the score was, what's actually happening on the field at the time. They appear to move clumsily. And then if they're off the field, which they really should be, they're also going to be maybe communicating slowly, a little bit incoherently. They might show changes to their mood, their behavior, their personality. So people that know them might be able to report these things best. And then, of course, if any loss of consciousness is observed, even briefly, a concussion very likely has occurred. If the concussion occurs and they come out of play and they're planning to see a medical professional, so maybe they'll come in and they'll see a physician like myself who has experience with treating concussions. Some of the things that are really helpful to bring to the visit with a medical provider is, are they taking any medications, whether these are over-the-counter medications or supplements? Please bring those with you. If you can explain what happened, what was the injury like, where did the force or the hit come from, and what part of the head, if any, got hit? Was there any loss of consciousness seen by anybody? And if so, for how long? Was there any memory loss noted after the injury? Did the athlete experience a seizure? Again, uncommon, but necessary for us to know. And very important for us to know is there any history of previous concussions and how many? Some of the risk factors for prolonged symptoms after a concussion are the number of prior concussions noted, and some sports, of course, are more prone to concussions, as well as prior injury. We also want to know about, does our athlete have any IEP or assistance for learning in school? Do they have any documented mood or anxiety disorder? Do they have any history of, for example, ADHD and take medication for that? The healthcare specialist will ask you some of these questions. They'll also maybe ask you some very individual additional questions that are specific to your child's risks. And then a number of validated tests are going to be performed. What we mean by validated is that these tests have been proven to be accurate in helping to diagnose and give a prognosis or recovery estimation for something like a mild traumatic brain injury or a sports concussion. At the end of the visit with a medical provider, you'll often also be given some same-day recommendations on the gradual steps to recovery. And those are going to be specific to what your child is presenting with and what their complaints are and how they specifically performed on the testing that we're going to be performing or giving them. Some of these recommendations, for example, might be like, we're going to build in rest breaks when they go back to school. So returning to learning is a super important first part of getting back to feeling like oneself. So going back to school is one of the first milestones that we want to see get back to usual. We don't rush this, and we send the kid back to school with accommodations. Maybe the lights bother them, so they'll be given accommodations that they can wear sunglasses. Maybe we need to reduce the amount of hours that they attend school, or postpone tests, or extend deadlines for assignments, because we want to reduce a little bit of the cognitive load and stress on the brain. This has been shown to shorten recovery time. If medications are advised, doses for Tylenol or ibuprofen will be discussed. If anxiety or stress are playing a big part of their concussion symptoms or prolongation of not feeling well, relaxations or different safe exercises for anxious children will also be provided by your healthcare provider. Another really important part of concussion recovery is keeping a very healthy circadian rhythm. And what this means is consistent routine awake and sleep cycles. We know this helps a lot with concussion recovery. So if the sun is up, they're staying awake as best they can, no long naps, and then they're sleeping at a consistent time at night, and they're not waking up or waking up in the middle of the night, having snacks, playing video games, and then going back to sleep. Reducing screen time is a very, very important part of what all family members, healthcare providers, athletic trainers, coaches, and guardians are going to recommend to the student athlete. Any screen time outside of school, we really want to try to minimize. The smaller the screen and the darker the room, the more stress it is on the brain. So that would be the worst criminal. But also at school, a lot of stuff is done on the screen now. So we can also give some advice for classroom reduction of screen time. This is very simple, surprisingly. Things can be printed, things can be actually, they can go old school analog, and the schools have always been more than willing to accommodate. We give a very simple program to the athlete to follow, and usually the parents are present in the room, and we all discuss this, come up with a plan that's going to work for the family, and make a decision on where we're going to see that athlete again. Really, we give the athlete about 14 days for symptoms to resolve completely before maybe specific concussion therapies are prescribed. As you can see on the slide, there is something called a return to play progression. And this has been studied, this has been executed for many years to confirm that it's safe and effective. And then this has also been endorsed by the CDC. And they break it down into 6 easy steps. So once the symptoms have resolved or the athlete has rested for about 48 hours, we're going to do that return to learn. And we're also going to do a simple program, for example, like walking in the neighborhood. The school will get a letter saying no PE right now, maybe some academic accommodations, but we're going to try that out. If the athlete feels good with that and 24 hours have passed, they can advance to step 2. And step 2 consists of light aerobic activity. This is about 5 to 10 minutes light jogging. No weightlifting right now, but just light activity under supervision. 24 hours pass, they feel great with that, no provocation of signs or symptoms. They're going to move to moderate intensity. So here comes a little bit more exercise, and these movements can include movements of the head. So you're not just moving in the forward plane, but you can move side to side and turn left to right and twist and up and down. And then if 24 hours go by, they can do heavy activities, sprinting, weightlifting, but not contact. They need to check in with the physician once they get to this stage to be cleared for practice, full contact, and then finally competition. These are the 6 RTP stages. What we would do is help to execute these along with the coach, the athletic trainer, and the family or the guardian to make sure that everything is moving smoothly on the road to recovery. I think that kind of summarizes some of the most salient points about concussion.
Fantastic. Diana, I am asking you to unmute. I don't know if you can do that on your phone. It's not working.
Hi,
okay.
Sally,
Yes.
Can you hear me?
I can. Please go ahead.
Oh, fantastic. I'm so very sorry that I wasn't able to start the program, but we are back up and running. And I do want to thank Sally for jumping in there, but I did want to give our fantastic, talented physician panel some formal introductions. I know Dr. Ashraf already did a wonderful presentation on concussion, but Just wanted to give our docs a little bit of an introduction. My name is Diana Toto. I'm the Administrative Director here for Sports and Rehabilitative Medicine. And all of our providers tonight are going to be presenting on behalf of the Musculoskeletal and Sports Medicine Institute. They are amazing. They provide around-the-clock access and care for your athletes from all levels, from middle school to rec to the weekend warriors, collegiate athletes, and all the way up to professionals. So we are so excited you guys could join us, and I apologize for the delayed introduction, but I did want to do them justice and give them a little preempt here. So Dr. Ashraf, thank you for your presentation on concussion. We're going to hit on some questions at the end of the program. So if you fire them in the chat like Sally suggested, that's wonderful. And if you have specific questions for our individual providers, we'll direct them right to them at the end. So Dr. Ashraf, who you just heard from, is an assistant professor with the Department of Physical Medicine and Rehabilitation with Rutgers, New Jersey Medical School, and she's also team physician for New Jersey City University. So thank you again, Dr. Ashraf, for kicking us off. Our next presenter is Dr. Louis Rizzio. Dr. Rizzio is one of our orthopedic surgeons here, who is also sports trained. He's our team orthopedist for New Jersey Institute of Technology, as well as Kane University. He's going to be jumping in now on throwing injury prevention. So I guess we'll jump right in to you, Dr. Rizzio, if you want to take it away.
Okay, thanks, Diana. Let me share my screen with you here. Sorry about that. Trying to get this to start again. Okay, can you see that okay?
No, I need you to share again, Doc.
Okay.
Yep.
Okay, sorry about that. It was better the first time I did it. Okay, so you can hear me okay?
Yes, we can.
Okay, so I'm going to talk a little bit about the prevention of throwing injuries. Typically, when we think about throwing injuries, we think about baseball and baseball pitchers, but many of these things apply to all overhead athletes, including volleyball, tennis, and swimming. The injury patterns that we see in baseball and throwing, of course, there are acute injuries that do occur, but we're going to focus predominantly on the overuse injuries, as I would say that those are the much more common injuries, and also injuries that I think we can have a better effect on preventing and dealing with, especially in younger athletes. Acute injuries span the things of collisions, getting hit by baseballs, hit by pitches, base running injuries, sliding, and things of that nature. A lot of these acute injuries are really, typically traditional accidents. They're unavoidable, but in some cases, protective gear may provide less injury or less severity of injury, such as like chest guards, goggles, face masks on helmets. All of these things are definitely beneficial, particularly in younger athletes, and are worth a consideration for these random events that are hard to predict. When we talk about baseball, it's a complex set of motions designed to wind up, generate force, and propel the baseball as fast as we possibly can. And with that, there is a high potential for repetitive overuse trauma to different parts of the upper extremity. At least 3 to 5 million children participate in sports, particularly baseball, annually. Some numbers suggest it's over 20 million. One of the biggest problems that we've seen with regards to baseball and overuse injuries is the year-round participation in baseball. There's an increasing pressure to specialize in sport at a young age. I've seen this with my own children. There's a high pressure to participate on multiple teams, particularly if your child is good. and effective as a youth player. Many teams want them to play. They want you to play on a club team. They want you to participate in tournaments and showcases. And then in addition to all of those games, there's a training pressure. Get pitching lessons, get more practices in, get in more reps. It's an ever evolving problem. My son, at the age of 9 or 10 years old, played about 75 games between spring and summer. And I look back on it now, and I sometimes wonder, what I was doing and allowing him to do it that much. But fortunately, he wasn't a pitcher. When we poll athletes at a young age and we ask them what they're experiencing during sports participation, 70% of our athletes report pain with throwing. 43% of them pitched on consecutive days, 30% or more play on multiple teams, and 19 to 20% have pitched multiple games on a single day. And the more alarming statistic is that almost half of them were encouraged to continue playing despite having arm pain. And that's really, that really is a parent and a coaching issue. And also the athletes have a pressure to sometimes not speak up and tell us when they're having pain. From 1995 to 2000, there was a 5-fold increase in the number of Tommy John surgeries in patients under the age of 18. I think that is a really alarming statistic. It speaks to the problem of sports specialization, year-round participation, showcases, tournaments, and lots of games. And 5% of youth pitchers are going to suffer a serious elbow or shoulder injury during their playing time between 8 and 18 years old. And the problem with that is that if we can prevent those 5% or even a few of those percent, we can actually extend the longevity of the athlete's playing career. The other thing we need to consider is other players are at risk. Catchers. We never really talk about catchers as a potential injury problem, but think about the fact that the catcher throws the ball every time the pitcher throws the ball for the most part, except unless there's a hit. And often the catchers catch more than one game in a tournament. So you may have different pitchers, but you have the same catcher, something to consider. So when it comes to injury patterns, there's a little bit of a difference in the injury pattern based on skeletal maturity. In my practice, my younger patients, what I typically see around the shoulder and elbow are stress reactions or stress fractures that typically involve the growth plate. Muscle strains are common. Osteochondritis lesions or damage to the bone and cartilage is common in the elbow with repetitive overuse injuries. In the adult, the injuries tend to be more focused around the soft tissues, such as the labrum and the rotator cuff, and in the elbow, the ulnar collateral ligament or Tommy John ligament. This is an MRI of a couple of my athletes who are skeletally immature, which is evidenced by the dark line here or the growth plate. This particular person has bright white signal in the medial epicondyle and the lateral epicondyle of the elbow, consistent with the stress reaction, also present in the back of the elbow and the olecranon. In the shoulder, we tend to see this bright white signal or inflammation around the growth plate of the proximal humerus, a very common pattern in skeletally immature athletes. Adults tend to be a little bit different. Here we see an avulsion of the ulnar collateral ligament in an acute injury in a throwing athlete. And on the right here, this is an example of a labral repair performed on actually a collegiate catcher who had a superior labral tear. Some of the big risk factors, common sense would indicate that the amount of throwing is the #1 risk factor for these types of injuries. And it includes the number of pitches, how frequently we pitch or throw, and also velocity. I'll get back to velocity in a second. But in addition, the improper rest periods, time between outings, preseason preparation is important. And of course, biomechanics. Players who have a better pitching biomechanics and form tend to get injured less. Some of that is natural and just natural ability, but a lot of it can be learned. I think, if you're as old as me, you remember Nolan Ryan, the guy pitched forever at 100 miles an hour before anybody did, and barely got hurt because he had perfect mechanics. Velocity is interesting because the ulnar collateral ligament, or the Tommy John ligament, can fail at velocities above 80 miles an hour. The thing is that the higher the velocity, the more likely the person is to continue to participate and get on to the next level. So I don't think encouraging people to throw slower is going to be an effective means of preventing injury. But it is an interesting statistic that the faster a person throws, the more likely they are to get injured. Physical maturity is a very interesting topic. I think that this is a psychological topic because we see it all the time. I've seen it in my own town, in my own kids' teams. Younger kids who are bigger, stronger, and faster, they tend to get put in the positions of more importance, such as pitching. They get played more, they get more innings, and there's a natural selection for those athletes to participate more because of their physical maturity. So being really big at a young age may not be the best thing for the athlete if they're getting played more because of that growth. So when it comes to prevention, there are some things that we can do. Really rest and attention to how often a person plays is the biggest factor in preventing injury, and pitching volume is certainly the #1 predictor of injury. The pitch type is an interesting topic. There's a lot of discussion about curve balls, breaking balls, and things of that nature, but there's a lot of confusing evidence whether or not it really is dangerous to throw curve balls. But in general, most people would accept limiting the amount of curve balls or not letting curve balls or breaking pitches be thrown before a person's skeletally mature. And rest between outings, given more time between pitching is the single most important thing you can do besides pitch count to prevent injury. The current USA Baseball recommendations, this is an online source or resource for parents and for coaches. They have a clear recommendation for how many pitches a person or an athlete should pitch based on their age. Then they also give you a clear recommendation for how many days you should rest in between outings, depending upon the number of pitches you've thrown that day. And also, please keep in mind that if you're in an off day, 1 or 2 days of rest from your last pitching outing, going to the pitching coach and throwing another 50 pitches doesn't count as rest. So you have to keep that in mind, that training has to be taken into consideration when we talk about rest days and how many pitches you throw. So again, consider how much you're throwing, include your pitching lessons in those number of throws as well. The recommendations currently are no one should be pitching more than 8 to 9 months a year. We recommend that coaches and parents pay attention to pitch counts and follow them diligently, and do not use radar guns at practices. Radar guns at practices, they do the obvious thing. Everybody tries to throw that much harder. So there's no benefit to radar guns at practices. It just increases the risk of people trying to overthrow to get a higher velocity. So I would recommend not using this. Any parents out there whose kids play on club teams, which many do now, you have to be careful with what tournament you're in. USABL, Perfect Game, Future Stars, whatever the tournament may be, they all do not have consistent pitch count limitations. Many times it's discretionary. You have to be on top of this and advocate for your child. Biomechanics and conditioning, getting practice, getting training, learning proper technique, proper body conditioning, avoiding asymmetries by these methods do actually prevent injury. But again, you can't be training every single day and be playing games every single day. Just again about the velocity, The average velocity in the MLB between 2008 and 2017 increased about 3 miles an hour. One of the training methods that people use are plyo balls or weighted baseballs to increase velocity. I certainly believe that they work. I certainly think that they make people stronger. They definitely have a positive effect, but they could lead to more injuries. So I would caution against overusing the plyo balls and be careful with that. But at the end of the day, telling someone to throw slower is never going to be an effective way to prevent injury, because throwing faster is what everybody wants. When it comes to asymmetries, we have a normal arc of motion in the shoulder. Throwing repetitive activity can lead to a interruption of this normal arc of motion and a loss of motion, particularly internal rotation, called a GERD or glenohumeral internal rotation deficit. When this occurs, the posterior capsule gets tight, the shoulder tends to sit in a superior and anterior position in the throwing motion, puts excess pressure on the labrum and rotator cuff, leading to internal impingement and eventually potentially labral tears, rotator cuff tears, and I've seen some elbow injuries as well from glenohumeral internal rotation deficit. Here's a picture of a person with internal impingement. They have a partial rotator cuff tear and a labral tear. So this is really the best thing that I've seen in a while on conditioning regarding preseason training. It's called the Yokohama Baseball 9 program. There's a series of 9 stretches that athletes are supposed to do that involve the upper extremity, but also the lower extremity to improve motion and the kinetic chain. Most of the power from pitching comes from the legs and the torso rather than the arms. So this is important to make sure you're working on the lower extremities as well. My personal favorite stretch is this one right here, the sleeper stretch, which really helps athletes reduce and eliminate internal rotation deficit. In addition to that, they came out with a Yokohama 9 strengthening program to go along with the stretching, which you can see here, does not use heavy weights, and does incorporate not only the upper extremities, but the torso and core, as well as the lower extremities, including flexibility and balance. These are very effective training programs. They're simple. They could be done at home with body weight and use of very light weights, and can help prevent injury. So the question is, do these things really work? And the answer is yes. In this particular study, the Yokohama 9 program reduced medial elbow injuries by 50%. Another study showed that stretching clearly decreases motion deficits. Many years ago, one of the team physicians for the Phillies put all of the athletes on this stretching program for the posterior capsule, and they found no labral tears over a 2-year period when the athletes adhered to this program. And in this particular study, it reduced injuries by 36%. So recommendations would be, obviously, proper mechanics is a good idea. When you're not in season, it's a good idea to get some training and conditioning with a coach that really understands mechanics. Please pay attention to pitch counts and rest recommendation. You shouldn't pitch in more than one league in the same season. You should avoid showcases. I know there's a lot of pressure to be in showcases. My kids do showcases. I try to limit them. But, honestly, doing a showcase and getting injured prevents you from getting to the next level. So staying healthy is more important. Never let your son pitch the same day and in 2 games. Don't pitch more than 8 to 9 months a year. And in general, we should probably avoid curveballs until you're skeletally mature. So if you do develop, or the athlete does develop pain while throwing, the initial recommendations of rest, ice, and anti-inflammatories are usually recommended. But it's my opinion that if your son or your daughter or any of your athletes are having pain while participating in overhead sports, a good sports medicine evaluation is worthwhile. Thank you.
Thank you, Dr. Rizzio, for that great presentation and for the great points you pointed out regarding overtraining and conditioning. I think all great things parents, I'm sure, are curious about, and the great information for the audience for sure. So I see some questions coming in. We will definitely address those to our panel in just a few minutes. I'm going to move on to our next presentation with Dr. Peter Deluca. Dr. Deluca is our sports-trained orthopedic surgeon here at Cooperman Barnabas Medical Center. He is a team orthopedist for the New Jersey Devils, as well as New Jersey City University. He's the former director of orthopedic surgery for the Philadelphia Flyers, former team physician and former team physician for the Philadelphia Eagles. Welcome, Dr. Deluca. He's going to be covering ACL prevention.
Thank you, Diana. I don't know if you can see my slides. I don't know why they're not working. They were working before.
Try advancing
Dr.
one.
Deluca, yeah, I saw them. If you want to go out and screen share again, I saw them right when you started.
I know they were there.
Mhm.
And then when I hit
There you
to
go.
go, when I hit from beginning, nothing happens.
Do you want to hit, just hit the enter or the space bar and see if they start queuing up? Okay.
Hold on. Let's see what happened there. There we go. Sorry
There
about
it
that. Thank you, Diana. Good evening, everyone. My talk tonight is on ACL prevention, which is actually a little bit of a misnomer because we can reduce the incidence of ACL tears, but we really can't stop them from being occurring. The exact incidence of ACL injury is unknown. It's estimated that 350,000 ACL reconstructions are performed annually in the United States. And despite surgical reconstruction, 79% of those athletes will develop osteoarthritis of the knee. 20% suffer re-injury within 2 years. 1 in 4 youths who suffer an ACL injury will suffer a second ACL injury in their sporting career. And athletes who suffer a knee injury prior to participation in D1 sports have an 8-fold increased risk of another knee injury during their D1 career. I mean, these statistics are pretty eye-opening and a bit startling. ACL injuries occur during dynamic activities that involve quick change of direction, a sudden deceleration, or jumping and landing. 80% of ACL injuries are non-contact. Female athletes are at risk 4 to 6 times greater than their male counterparts. Female high school athletes have a 9-fold increased risk, and female college athletes have a 5-fold increased risk. And there's a lot of different reasons for that. Some of these reasons we can modify or change, and some we cannot. Those that we cannot is one shown here, is that females tend to have a wider pelvis. And what that does, it increases the Q angle or quadriceps angle, and that puts undue stress on the ACL and MCL. Another thing we cannot correct is that females tend to have a narrow intercondylar notch. This intercondylar notch is the end of the femur or thigh bone where the ACL lives. And when that area is all cramped and tight, it makes it more prone for the ACL to tear. Another factor that we can't control is that people are what we call have generalized ligamentous laxity or double jointed. So those are risks that we really can't affect with any type of exercise program. But there are some that we can. And one, on this slide here, you see girls tend to be quad dominant. They tend to activate their quads a little bit more than their hamstrings. And when that occurs, as this red arrow shows, it pulls the tibia forward, which stretches the ACL and makes it more prone to tearing. The next picture has to do with landing. Now, when I say landing, I know people thinking you come down from a jump, but we refer to landing also as someone when they change direction. They plant that foot and quickly change direction. That's considered a landing also. And females tend to land with their feet closer together. Their knee is straighter, and their whole lower extremity is at an angle we call valgus or knock-kneed. And one thing you should take home from this talk is that knock-kneed or valgus is bad. Another interesting statistic is that ACL injuries cost the healthcare system about $500 million a year. So you can see that an ACL injury is devastating, not only to the athlete, but also to society in general. So now the next question is, how do we do with our surgeries? And this is a study from 2017, and it looked at young athletes ages 14 to 19 who underwent ACL reconstruction using patella tendon or hamstring autograft, which are the two types of tissues that we commonly use to reconstruct the ACL. And what they found is that there was 19% ipsilateral ACL graft failure, 13% contralateral ACL tear rate, for an overall injury rate of 32%. I don't know how you look at those numbers to me, but that's still pretty high. When we talk about ACL outcomes, though, we just don't talk about failure or re-tear. We also talk about function. And in 2020, there was a study that showed that 80% returned to some type of sport. Okay, that's reasonable, but only a little more than half actually returned to the same competitive sport they did prior to tearing their ACL. So when we critically look at these outcomes, we realize that we haven't done as well as we thought with ACL reconstructions. So hopefully what I've shown so far is that ACL injuries could be disastrous. And the surgery, both re-tear rate as well as function, is good, but not ideal. So a lot of energy now has been directed towards ACL prevention. And there is strong evidence in support of ACL injury prevention programs demonstrated by a risk reduction of 52% in females and 85% in male athletes. It's recommended that these exercises be started at an early age, almost pre-adolescent, because fewer ACL injuries were documented in younger athletes who perform neuromuscular training compared to older athletes who perform the same type of exercises. Each session should be about 20 to 30 minutes and performed several times a week. Ideally, it'd be great if you can start these exercises in the preseason and definitely continue them throughout the season. And the key is doing them, but not just doing them, you have to do them correctly. Studies have shown that if there's a compliance rate of just 66%, there's actually a risk reduction of 82% in tearing your ACL. So what exercises should you perform? Well, studies have shown that you really need a variety of exercises, not just one type. And what we found is that plyometric exercises, neuromuscular training, which is a combination of balance and agility exercises, and strength training are the best to reduce ACL injuries. So plyometrics, what is it? It's jump training. It's learning to train your muscles how to jump and land. And you can see there's different types. There's the beginner and advanced exercises. Now, you don't have to do all of these in each session. You can do just 3 to 5 of them per session. The key to these particular exercises is your technique, because if you're doing them incorrectly, you're not helping yourself. So you really need someone that can give you some feedback while you're doing them, and also to watch yourself in a mirror while you're doing these type of exercises. Strength training actually has been one exercise that has been shown to be the greatest in reducing ACL injuries. But again, you just can't do strength training. You have to couple it with the other 2 types of exercises. One thing I want to show you from this slide is look at these exercises. Again, they're beginner and advanced, but there's no heavy machinery, no special equipment. So you have no excuse to not do these exercises. They can be done in your bedroom, in your basement, in your backyard, anywhere. The key, again, is just doing them. There's a lot of different programs that are out there. PEP, which stands for Prevent Injury and Enhance Performance, was probably one of the original ones. There's actually a program for coaches called KIP, and you can get these instructions online. And then Sports Metrics, which is based out of Cincinnati. These are the ones that have been the most popular and the ones that those studies that I showed you earlier followed. So they do work. What I want to do is show you a quick video because I think it helps to see these exercises. Now, I think when you see them, you're going to say there's no way they help, but they do. So I'm going to speed through these for sake of time, but you can see, you can do them before practice. So here they're just doing a shuttle run, just a warm-up, a regular warm-up that you would do before every practice. And then we're going to get into some strengthening exercises. And this, they just did 2. That's all you have to do. 2 exercises before a practice. And these are walking lunges. And what I want to show you is this girl here, because she's doing it incorrectly. See how she wobbled there? She has no trunk stability. Her leg is wobbling into that valgus position. She is a setup for an ACL injury. Unfortunately, she's the one that'll come in your office and say, Doc, I was doing the exercises and I still tore my ACL. But unfortunately, she was doing them incorrectly. She's the one that really needs someone to instruct her. Toe raises. Again, we're strengthening muscles that have been shown to protect the ACL. Now we're going to go into plyometric exercises. And here they picked 5. But again, you can just do 3 if you want to. Again, I want you to look at the girl in this red hoodie sweatshirt. Look how narrow her feet are together. And her leg goes into that valgus position. Compared to her technique is perfect. Feet wide apart, knees slightly bent. And now you want to do these type of jumping exercises in 2 planes, one in the frontal plane and one lateral, because you're training different muscles. And then you want to do single leg hops so that you're working both legs individually. And then there's these scissor jumps. And then the last exercise is the agility exercises. And again, well, here you're trying to create a muscle memory so that your muscles know what to do when you decelerate and change direction. So you don't have to do these quickly. You can just do them slowly, but pay attention to the principles that I talked about. Keeping your legs far apart, keeping your knees slightly bent, and your knee centered over your foot. Here they just ran straight ahead and stopped. On the next one, you'll see they're planting that foot. Now look how wide her feet are, and her knee is slightly bent. That's perfect technique. And when she does it in a game, hopefully her muscles will remember that and decrease the incidence of ACL injuries. And then the last one is a bounding exercise. And there's a lot of these different types of agility drills also. So in summary, injury to the ACL is the leading knee complication in sports and the primary reason why athletes lose so much time. Surgical outcomes are good, but they're not great. High percentage of patients after ACL injuries with or without surgery will develop arthritis. ACL prevention programs have been shown scientifically to decrease the risk of injury for non-contact mechanisms. They obviously will not help with the contact injuries. And these exercises can be instructed by athletic trainers and physical therapists. I personally would like to see coaches set aside time before practice. All you need is about 15 to 20 minutes to perform these exercises under the watchful eyes of the athletic trainers. And I think if this is done, we will definitely see a reduction in ACL injuries. Thank you.
Thank you, Dr. Deluca. That was awesome. And I think the visuals were super helpful, especially being when I was a young athlete. I know there was plenty of things I was doing wrong, and to have those corrective techniques, I think is really important to see for many of us. So appreciate taking your time to review that, and we'll fire around some questions in just a few minutes. All right, so I'd like to keep the program going here. We're going to move on to Dr. Jason Christophiak as our final presenter of the evening. Dr. Christophiak is our Medical Director of Sports Medicine here at Cooperman Barnabas Medical Center, and also of the Matthew J. Morahan III Health Assessment Center for Athletes. He's also our assistant team physician with Rutgers Athletics. He works extremely close with Rutgers football, and I work very closely with him day in and day out. Looking very forward to hearing him present tonight. Dr. Christophiak, you're up.
Thank you, Diana, and thank you for all of our participants who are on tonight, and for all of our guest speakers thus far. And thank you for bearing with some technical difficulties. I'm just going to share my screen here and get my slides up. Great. Just want to kind of verify if everyone can hear me and see my slides.
Yes, we can.
Great, thank you. So I'm going to be closing out today's presentation, talking about cardiovascular screening in athletes. Nothing to disclose, and just a quick overview. I'm going to be briefly reviewing sudden cardiac death in the athlete, history and physical, and the EKG or electrocardiogram, and then we're going to open up for the Q&A chat with the rest of the group. So every year, depending on where the student athlete falls in the cycle, there's a pre-participation physical that needs to get done to clear them to participate in athletics. And one of the largest things that physicians are really screening for is actually the signs and symptoms or any type of physical tell or family history that can predispose the individual to sudden cardiac death. And that's a big part of what we're looking for. Sudden cardiac death, just here on, it's going to be SCD for short. It's the most common cause of medical death in NCAA student athletes. And it's a very high amount for any really young student athlete. The incidence varies depending on what type of research you look for, but a general one that seems to come up a lot is about 1 in 53,000 athletes per year. And there's a lot of athletes, so that number doesn't necessarily look that large, but just 1 in any number of a sudden cardiac death, which is possibly preventable, is one too many. There is an increase in men and basketball athletes, but just in general, the incidence, they do vary. Sudden cardiac death sometimes is the first clinical manifestation of a cardiac disease, and this is actually in up to 60 to 80% of athletes who have sudden cardiac death. And that's quite scary to know that someone who is seemingly perfectly fine can literally be fine 1 minute, sprinting the next minute, and then unfortunately collapse with a cardiac arrest and may not make that event. And that occurs in about 60, 80% of the time, where there is no feature that could possibly leading up to it. But through history and physical and cardiovascular screening, there's ways of putting people into risk stratifications and seeing who might need a further evaluation or a cardiac evaluation or seeing a cardiologist. So exercise is a known trigger, and that could actually, again, unmask these cardiac diseases that an individual may or may not know that they have. A little bit more about sudden cardiac death in athletes. One of the most common causes is something called hypertrophic cardiomyopathy. Its acronym is HCM or HOCM. It's something that it's pretty common. A lot of people are aware of it. It accounts for more than 1/3 of cases in the United States alone, and varies elsewhere in the world. But approximately 95% of the individuals actually show abnormalities on an ECG, and an ECG standing for electrocardiogram, which can be detected on an ECG screening. Now that's really interesting. So a lot of the student athletes I see, I usually see them between the ages of about 18, 17 to about 24 to 26. And a lot of them have never had an ECG in their life before. So the first time that we're actually doing an ECG is the first time they ever had it. And that's really interesting that if you look at that for a screening tool, being able to possibly detect up to 95% of individuals, and that does vary by research. This is just one very specific research, but to be able to do a test, which I'll describe in a minute, that is inexpensive, it is easy to perform, it's non-invasive, it takes a very little time and has very little risk to possibly be able to detect an abnormality that can save someone's life. It's really an invaluable tool for a lot of our sports medicine physicians. The one thing though to comment on is that ECG unfortunately can identify everything. There are individuals who have premature plaques in their arteries that you would expect in someone that might be 50 years of age or older with a lot of risk factors, or congenital artery or vein abnormalities within the heart. That's something that the ECG often does not pick up on, and that's more of the history and the physical and the family history that can lead for a more appropriate diagnostic or screening tests to be done from a cardiologist standpoint. So when we're looking at the pre-participation physical, we're highly looking at the risk for sudden cardiac death, and we're incorporating some of these tools to be able to modify those risk factors. So when your son or daughter comes to see us for the physical, there's a lot of things that we're screening for, but a lot of the questions that we're asking are, do you ever have a history of a heart issue? Does anyone in your family or immediate family have ever had a sudden cardiac event, whether that's death or just an event? Was there any type of early coronary artery disease or any type of arrhythmias? Do you get short of breath or have chest pain with activity? Have you ever passed out with sport or activity? Have you ever been diagnosed with a heart murmur? Have you ever been told you had a heart murmur? Have you ever had an EKG before any other cardiac testing? So these are a lot of the questions that we ask regarding cardiovascular screening. And depending on what school system, district, and level, an ECG might be required or highly recommended or not. It really depends. I have found that incorporating ECG into the CV screening process can further aid in detection of the abnormalities. Just in the last few weeks, during pre-participation physicals at the college level, I detected 2 individuals who had potentially lethal issues with their heart that we were able to catch, and they were able to go on and get cardiovascular screened, and they're going to get procedures done to allow them to participate in sports. So a lot of the times parents say to me, well, if I get the EKG, are we going to find something we don't want to find? And it's an interesting question. It's a fair question. And I always respond with, well, if it's something that can predispose your son or daughter to a sudden cardiac death, then absolutely we want to find it. Now, are there incidental findings that we may need to halt participation for while we're doing a further evaluation? Absolutely. But safety, primary game. I think that's a really good thing. If we find something, let the physicians, let the specialists do their job. Let us investigate it. A high percentage time out of not, we never find something on there that's going to permanently preclude someone from playing a sport unless there's something that would put them at risk for a sudden cardiac death. And there's still things that sometimes can be done from the cardiovascular standpoint to allow them to still participate in sports later. But if we don't know about it, then there's no way to detect it unless it's too late. As I mentioned, ECGs are not typically required for sports clearances. At the college level, there's a lot of institutions that we have protocols that requires every single person to have one. At the high school level in New Jersey, it's really it's not necessarily required, but there are districts and some schools that do highly recommend it or offer it as a part of their physical process. Again, ECGs are inexpensive. They're non-invasive. They can be done usually in less than 3 minutes. That's being fair, probably even sooner. It just involves the student athlete to just lay down and have different leads that are connected to a machine. And it just measures the electrical activity for 10 seconds. And if we pick up on abnormalities with the EKG, that will prompt a further cardiac evaluation, and that can potentially save someone's life. So this is just a very quick example of an individual who had hypertrophic cardiomyopathy. That is a risk for sudden cardiac death because the heart enlarges in an area that should not be enlarged, and it can restrict blood flow and cause arrhythmias and lethal issues to occur. But I don't know if you can see my mouse, but these areas over here, all these waves that are inverted here and here, these are telltale signs of that there's something going on with the young athlete's heart that needs to be further evaluated. And the next step is we simply just restrict participation, and we have them go see a cardiologist, and then they do further testing, such as an echocardiogram where they put gel on the probe and they take a close look at the septum of the heart and look at the valves and general live structure of the heart. So in kind of closing, sudden cardiac death is a really critical part of the pre-participation physical. Every physician is looking out for it. That's where a lot of our training for the pre-participation exams are really geared towards. And in my opinion, and a lot of the colleagues I practice with, EKGs are a really important tool, a really important screening tool. It can save a life, and it's highly recommended. And this is a plug. This is through our Matthew J. Morahan Center, which I medically direct. We do cardiac and concussion screenings for young athletes. We've done more than 40,000 since 2010. And on September 24th of this year, at the South Mountain Recreation Complex in West Orange, we're going to offer these screenings for concussion screenings as well as cardiac screenings. So if everything I said struck a chord and you want your son or daughter to have an EKG, this is where you can get it, and we're happy to support the community and do these screenings.
Thanks, Dr. Christophiak. That's really important information to get to our families out there. And we can't preach enough the importance of these preventative screenings and taking all these precautions to keep your young son or daughter safe. Hopefully you learned a lot this evening that can help you in the future. And I did see some questions about, is this a taped event and will it be circulated? And we will certainly get all this information out. I see some really good questions in the chat. So I think, one, I just want to thank everyone who has stuck with us for this full hour. You all are amazing bearing with our technical issues. But I also think since you're still here, why don't we go ahead and answer some of your questions. So the first one is for Dr. Ashroff. Dr. Ashroff, do you know about the Q collar? And if so, what do you think about it?
Okay. Yeah, I know about the Q collar. I don't have any crazy big supportive thoughts about it. So anyone who's not familiar with it, it is a very tight fitting half collar that goes around the posterior neck. And the goal of it is to increase blood restriction on the veins of the neck. Imagine how comfortable is that? And the goal and the theory behind it is it decreases blood from leaving your brain. So the brain is a little bit more snugly fit in your skull. This came out after a 200-person study supported that, and it may show benefits in the deep brain tissue, and the FDA approved it. It costs, I don't know, between $200 and $300 last time I looked when it came out. One of the things that you can kind of imagine is that's not very comfortable. It also gives athletes possibly a false sense of safety because they think that it can prevent a concussion. And really, if you look at who could be an early adopter, the NFL really has not utilized it. So I don't think that many athletes found it to be helpful, and it definitely can't replace a helmet, but it exists. And I think it was a soft call for the FDA to let it go to market so quickly.
Thank you, Dr. Ashroff. Dr. K, do you have anything to add there? I know you've had some overlap with Q collar as well.
Yeah, absolutely. So there's a few professional athletes who swear by it. I think some of the original research that's currently available is really looking at more long-term quote unquote prevention of maybe CT or chronic encephalopathy. Chronic traumatic encephalopathy. So I haven't really seen great literature to support the ability to quote unquote prevent an acute concussive event. I find a lot of that to be more based on just good technique in sport, making sure the neck has good mass, muscle mass, and more on just looking at ways of, especially for example, for football, is clean tackling techniques, not leading with the crown of your helmet. Don't hit anything you can't see, right? No cheap shots and things like that. So I don't personally recommend the Q collar just because I haven't seen its proven benefits, but I do know that there are many professional athletes and non-professional athletes that kind of swear by it. But I definitely think that there's room for more medical literature and more research regarding that.
Great. Thank you both. Appreciate it. This next one is for you, Dr. Rizzio. Do you know if there's any recommendations for softball pitching?
Yeah, so the softball pitch counts and recommendations are out there. They're similar to baseball. The idea of rest and time off between outings there are recommendations online for that as well. They're a little bit different and vary to some degree than baseball, but they're similar. In addition, when it comes to prevention and conditioning, softball really can be benefited by lower extremity and core strengthening, and proper mechanics, of course, is a big thing. It's just that the mechanics are different for a softball pitch than versus a baseball pitch, but the same general rules apply. Proper mechanics, good form, lower extremity, core strengthening, and proper rest and intervals between outings is what's recommended.
Okay, great, thank you. And then our next question looks to be for Dr. Deluca. So it's regarding the stats on ACL tear. Is that primarily because they had surgery? Is there a better outcome if they follow the prevention plans post-discharge from rehab strictly?
So I'm not exactly sure what the question is aimed at. Obviously, when you tear your ACL, you're faced with a decision: do you have surgery or not? And it's clear that in a young athletic person, electing not to have surgery is very devastating. I mean, studies have shown that you start to increase your incidence of tearing your meniscus, you start to damage your articular cartilage, and you will end up definitely with osteoarthritis at a younger age. And plus, you won't be able to participate in any of those sports. So when you make the decision of going ahead and having surgery, then, unfortunately, nothing that we're using to reconstruct the ACL is stronger than what you were born with. So there's always a risk. But then you start looking closely at why these fail, and there's a lot of different reasons, going from the biology of the graft, because your body's changing it from a tendon into a ligament, and there's still some controversy how long that takes. Some people believe it can take as long as 2 years to fully reach its complete tensile strength. Sometimes it's technical errors. The way the graft was put in can lead to failures. Not addressing or not able to address the risk factors that we can't control, like the person that is double jointed. There's other risk factors such as the shape of the tibia at the top. Some people have a posterior tibial slope where it should be somewhat relatively flat. And those that have an increased posterior slope have an increased risk of tearing their ACL and re-tearing the graft. So there's a lot of different reasons. Another reason is why they tear in the first place. Maybe they had poor neuromuscular control to begin with, and that was never corrected in their rehab afterwards. So they're going to have the same risk as they did before. So I think if your question is, should they have surgery or not, I would say definitely they should have surgery. And then we have to address the rehab issues with that afterwards.
And just kind of going along with that, another question just came in regarding like correlation with the foot and ankle, and should you have any considerations regarding podiatry for like custom molded orthotics for prevention of ACL? Is that a consideration, or?
I haven't seen that to be a factor in reducing ACL tears. Whether you have a flat foot or you dynamically pronate, that really hasn't been shown to really decrease the risk of or increase the risk of ACL tears. So I don't know if it's worth the investment. I think just doing the exercises probably the best thing.
Okay. And then our last question here, do you recommend surgery for a partial ACL tear?
That's always the hot topic, because there's no way to tell how much is torn. As a general rule, people always go by if 50% or more than 50% is torn, then you should have it reconstructed. It's always a tough call. Sometimes you can tell by your exam if they're really loose or if they have other risk factors, like they have that generalized ligamentous laxity, then you probably would want to go ahead and reconstruct their ACL. Some people will go as far as taking them to the operating room, doing an exam under anesthesia, and then putting the arthroscope in and actually probing what's left of the ACL to make that decision. So it's always a tough decision. In professional athletes, we've gone both ways, whether we've let them play and see if they take the risk of tearing it, or gone in arthroscopically and evaluated the ACL that way.
Thank you. Dr. Rizzio, do you have anything to add before we conclude? I'm sure you have some thoughts on this as well.
Yeah, I'm just, regarding the ACL, I mean, I think that usually in my hands, I can get a fairly decent feel for whether or not a partial ACL tear is going to need surgery or not, based on a comparison between side to side. But certainly the 50% rule and having a look with the scope and planning to do the reconstruction is often beneficial. But the physical exam is often pretty telling. And in terms of the re-tear rates, I think that 1 in 4 re-tearing seems a little high, depending on what you read and who you listen to, but definitely the trend has been towards delaying return to sports for a longer period of time. It seems that every month that you delay return to sports, there's about a 3 or 4 or so % reduction in re-tear rates. And certainly graft choice, it's pretty clear now that doing a cadaver or allograft reconstruction in a younger competitive athlete is really just significantly increasing your risk of re-tearing. So graft choice is important, return to play time is important, and of course, rehab, proper mechanics, and proprioception training is very important as well.
Well, thank you so much, everybody on the panel, for this evening and for this awesome information. We want to thank everyone in the audience for, again, sticking it out with us for this time and giving us your full attention. I know that our marketing team has distributed a lot of great information on our providers and how to access us. We have a fantastic athletic concierge program, and we are kind of at your beck and call. If you need anything, we're here for you. From preseason to anything related to injury, we're available. So please don't hesitate to keep an eye out for some of our upcoming events, or anything you may need. Like Dr. Christophiak mentioned regarding our screening, that's all posted on our web pages that was sent to all of you previously. So I think that about wraps us up, and I want to thank you all for attending. We'll talk to you all soon.